one of the things we want to look at is why racialized systems can't be fixed with a class-based colorblind policies. This is important because this is the dominant way that we want to identify. You hear people say it all the time. If we fix things for everybody, then blacks will be helped. If we improve things for everybody, then blacks will be helped. And the answer is, of course, that if there's a gap, and that's what we're talking about fixing, removing the gap between whatever that gap is and all these different systems. We're not just talking about improving educational opportunities for blacks so that they have higher educational attainment. We're talking about completely eliminating a gap between blacks and whites so that there's no longer a gap. Those are two different goals. And so if I work on improving things for everyone, that is, if I am 10 steps behind you on the ladder, and everyone moves up 5 steps, I'm still 10 steps behind you. In order for the gap to be removed, when you move up 5 steps, I will have to move up 15 steps in order for the gap to be removed. And in order for that to happen, there has to be specific targeted programs on closing the gap. I want to illustrate the racial-based nature of at least one system, and in this case, the healthcare system. So when we talk about the problems of the healthcare system, in terms of race, there's basically 5 categories that we can use to look at that. Or at least there's 5 categories that I use to look at it. First of all, the lack of universal access. And generally speaking, when people discuss the lack of universal access, they generally are talking about inability to pay. But inability to pay is only one part of not having access. You have to also have facilities in your neighborhood. You have to have doctors in your neighborhood, providers in your neighborhood, and you have to have providers who will provide the services to you. And so just focusing on ability to pay won't be enough. We have barriers to hospitals and other institutions, not just their physical availability barriers, but even when they're available, barriers to getting into hospitals. We have a concept called patient dumping, which is illegal, but it still occurs. That's when hospitals direct people to poor people to different hospitals. And you say, oh, well, that's a class issue. Yes, but they found that black poor people and Latino poor people are more likely to be dumped than white poor people. And so there once again is a race issue. We find barriers to nursing homes. In fact, the barriers to nursing homes is an excellent illustration of a neutral policy that has a race impact. In this case, the primary beneficiary of Medicaid, which will pay for nursing home care, is middle-class white women. Now, you would say, well, Medicaid is for the poor. How is it that middle-class white women benefit for it? Well, it's because of a couple of policies and practices that come together. First of all, most nursing home beds are for profit beds. And the Medicaid regulation allows a nursing home to limit the number of Medicaid beds that they will have. So what you will have in a nursing home, for instance, if you have 100 beds, maybe 10 of those beds are for the poor or for Medicaid. The other 90 is for people who can pay. Now, what is the best way then to get into the nursing home when a bed is to be able to pay? So what happens is that a for-pay bed comes open, and a middle-class white woman, middle class have to be able to pay, white because they're more whites who are in that middle class category, and woman because men die younger. And so middle class white women go into a nursing home. Now, these women aren't rich, and they don't have a lot of money. Maybe they have a house and some savings. And so when they start paying the nursing home bill at $5,000 a month, it's this long before they have exhausted all their resources and they are now poor, the newly poor. And so they apply for Medicaid and they are accepted into Medicaid. Meanwhile, a Medicaid bed opens up. And so here's what's happened. You have a middle-class white woman in the nursing home in a for-pay bed that she can no longer afford, who qualifies for Medicaid. And you have a always poor black woman waiting to get into the nursing home into a Medicaid bed. What does the director of the nursing home do? Does she kick out the now poor white woman so that she because she's just newly poor, and let in the black woman who's standing outside in line? Or does she just transfer the white woman into the Medicaid bed, realizing that the Medicaid bed is paperwork, it's not an actual bed? And so there's been lawsuits over this, because what they found is that the historical poor trying to get into Medicaid beds were having a hard time because the newly poor middle-class white women were taking them up because of this policy and practice. You also have barriers to physicians and providers. One of those barriers is the failure of medical schools to train sufficient numbers of family practice internists and providers to work in minority communities. There are clear studies that show that that you can predict what kind of community a doctor will work in based on the kind of community they come from, and that if you want doctors to go back to certain communities, then you have to train people from those kind of communities. So if you want people to go back to rural Arkansas, then you have to train people who come from the rural South, because they're more likely to go back to those kinds of places. And the same is true based on race. And yet, medicine is still not sort of looking at this, doing geographic and racial admission to serve medically underserved areas. And the final racial barrier is the racial disparities in treatment.